Good evening once again. I'll be speaking on why, when, how to pursue a Retina Fellowship. Now, this presentation, though, is on Retina Fellowship. I think a lot of points here are an overlap for any other subspecialty as such. If you look at our typical residency training module in India, I have flagged the various aspects which I feel are parts of residency training. The ones that I've flagged in green, I think most of our training modules necessarily as a basic cover that, which is clinical examination, surgical skill, and theory knowledge. Now, to what extent this is covered will vary from program to program based on the facilities they have, but largely most of our training is on this. But a holistic learning would include research, would include teaching, passing on whatever you learn to your juniors, and I feel it should get topped up with some understanding in administration, because most of us are going to be in practices which you may be handling on your own, or even if you are in an institute, you may be in charge of some sort of an administration. So what is flagged in red is definitely not, I feel, something that is taught to us in residency or our teaching programs. Over the years, largely over the last decade, if you see, there have been a lot of articles, in Indian journals specifically talking of the Indian scenario of how our medical college residency programs run. And save a few big government hospitals and a few big institutes, we see that there's a wide variation in quality. There's inadequate supervised training, which becomes very crucial in ophthalmology. Theoretical knowledge, well, yes, if there is a patient load, if you are a high-end hospital based on CET cutoffs, then you're going to get good students. Good students will read on their own many a times. So theoretical knowledge is there, but there may be a practical shortfall. And at the end of 3 years, as an ophthalmic resident, you are left with a feeling of inadequacy at the end of 3 years of training. So when you look at that, you see multiple training programs along the country, teaching brushing of skills for various residents. Now, why are they present? It's a part of the demand-supply mechanics. This in itself tells us that there's some amount of inadequacy as far as the residency programs go. If you look at the surge of specialty practice, over the years, these are US figures, you will see that the trend for a general ophthalmologist has started to come down, whereas a trend for a subspecialist has started to go up. And it's not just about our field or our peers as such, but even for the public in general, a lot of people now have awareness that there is a retina specialist, there is a cornea specialist, so they often want to get an opinion from that particular level of specialist for their eyes. So when we look at Retina Fellowship per se, or for any fellowship for that matter, when we ask when should we be doing a Retina Fellowship, I think the answer is very individualistic. One needs to know what is the intent. So if you are looking for a particular fellowship, what is your intent? Do you have X level of skill which is adequate to do the type of practice that you are planning? And maybe you're looking just for a top-up. Say you are planning to do a good cataract practice, as one of the interviewees was explaining. You know SICS, you know phaco well, you don't know femtosecond laser. Now, I would, in my book, consider it as a top-up skill. My practice is not going to get hampered if I don't know that skill, right? So in that situation, the when can wait. You can go ahead, possibly start your practice, settle down, then reach a point where you feel, okay, fine, now I can take some time off and maybe, get a top up on my skill and then come back, right? So that is one aspect. Second is when it's a part of knowledge which is absolutely essential for you to carry out your practice. In that situation, I feel the when should be in continuity. Because if you break the continuity of learning, go back to practice, possibly you're attempting to settle down, with your family, in your family life, those things then make it very difficult for you to possibly come back and then, enter into a fellowship. So the when has to be individualistic, and it has to be answered based on what you are looking at. A general rule, always early bird gets the worm, earlier the better. Whatever you need to do, if it's clear in your mind, just finish it off. Whether to do or not to do Retina Fellowships, I think there are 3 bullet points which I have in my mind. There has to be a passion. Retina is a tough subspecialty to train in. As you would know, indirect ophthalmoscopy, so just seeing the retina is a skill by itself. Now, let alone being able to see it well, being able to diagnose and then, make your differentials and come down to treatment. So you need to have a lot of passion. You should not be just attempting to do retina fellowship so that, I know one more skill. You should be really tuned for it. There should be a need to learn your retina practice. Everybody currently, like the interviewer panel also told you, you should have some thought of what and how you're going to practice few years down the line. In that particular setup where you will be practicing, are you going to see these patients? If you're not going to see these patients, what is the point of getting that skill? So there has to be a definite need for learning that additional skill in practice going ahead based on your eventual or tentative geographic destination. If the decision is made, okay, fine, I'm going to go ahead and do retina practice, consider what your options are, national and internationally. My previous speaker nicely showed the country distribution of big centers that are present. So know about those, check with the resources of those institutes beforehand, do some groundwork on the institute and the faculty. Each and everything nowadays is getting more and more compartmentalized. So if you want to do a retina fellowship at a particular place, it would be good to read about and learn about the faculty who are at that place. What are the interests of those faculty? You can find that out easily based on the type of talks that they take. Largely, you will find settled faculty speaking on X topic. You will not find them deviating and speaking on anything that they want. So you would get a fair idea of where their interests lie, and wherever their interests lie, those topics you can be relatively sure are going to get covered really well in the fellowship program. So that is important. Know the faculty, reach out to past fellows. There's nothing like getting an opinion and advice from somebody who's your age, who's been there, done that. So reach out to past fellows. You will get an absolute immediate sort of a hint of how the fellowship program in that particular place is running. What are the pros, what are the cons, and how you deal with those. And look for a place which has a blend of academics and academic opportunities, because that is what is going to make you holistic. Surgery or being able to operate is one part of a fellowship, but the complete understanding of topics would come if you also have a blend of academics in whichever place you begin your fellowship. Now, once your course is about to start or once you have got selected, most big places will have a rough rotation in place. It's a template based on which the names are added both for fellows and faculty. So try to get a hang of what is the rotational template in that place. For example, if I give you my example, when I used to rotate with different faculty, if I'm with a faculty who's largely dealing with ROP, then I'm rotating next, I know I'm rotating next to a faculty who is going to largely deal with uveitis. Around 4 or 5 weeks before my rotation, I would stop reading on ROP, I would shift gears and start reading a little more on uveitis. What I mean to say is, don't end up day one blank. Do some groundwork. If you do some groundwork, if you anticipate and read on certain things, that gives you a heads up with the particular faculty with whom you are there in the clinic. As you would know, fellowships are they're giving you learning on the move. So the person is not only teaching you, is also seeing patients at the same time. So if you are okay with the basics, then it allows an easy ground for escalating the discussion. The discussion can go at a higher level. You can gain more out of the particular discussion that you are doing with the faculty. Also, it's an indirect evidence that the particular candidate rotating with me is serious, has prepared well, and is ready to deep dive to a higher level. Observe, listen, and reflect. Throughout fellowship, even in fellowship interviews, we often get answers where a particular person says, I want to learn this surgery, I want to learn this surgery. Surgery is one aspect. Surgery is possibly one of the simpler aspects. What is important is to observe everything that is happening while your fellowship is going on. Listen rather than just hear, and reflect back at the end of the days with small notes as to what you learned at the end of the day. I'll tell you, you learn a lot of things in one day, but sometimes it is so difficult because you did not put your mind to. Many a times at the end of the day, when I ask the fellow who was posted with me, can you tell me 3 things that you learned today? He's blank. By the next day, he's able to come up with that. So now we have tried to imbibe that at the end of every day at LVPI, and we ask the fellow, can you jot down 3 things that you learned today? And that is when you realize that if you pay attention, there are so many nice things that come out each and every day. Prepare for the ORs. Whenever you are in a specialty setup, the entire preparation has to be more detailed. It is now not just ophthalmology, you are looking at retina. So for example, my mental list that I tell fellows is, if you are coming with me, going to get scrubbed the next day for cases, I want you to read, or I want you to have a mental plan of 4 things about that particular patient. You have read the sheet or you have seen the patient, so what is your plan for that patient? Are there any special requirements in this particular case other than what is usual? What difficulties do I anticipate in the surgery? If I find difficulties, how will I tackle? So I feel if you have this homework before each and every case that you are going to face, you will be much more better prepared. So if there are any special requirements, suppose it's a retinal detachment with a large choroidal detachment, one of your special requirements will possibly be a large cannula, 6 millimeter cannula, and not the standard 4 cannula. So if you have done this thought process before, as the patient is shifting in, you are going to tell the scrub nurse, I want a 6 ready. Rather than be ready, make a port entry and then realize, oh no, I put a 4 sister, please give me a 6 Then you are disturbing everything, right? So if these actively you pursue, then you keep getting better and better. Developing your academic portfolio. In fellowship, again, you are learning, you are getting better at one step higher than what you would be doing in residency. So keep a lookout for interesting cases, keep a lookout for case series, possible retrospective studies that you can do. Keep small targets. Target 2 to 3 case reports, say 1 or 2 retrospective series that you can work every 6 months. It adds tremendous value to your CV. Akshay just spoke on how you build a CV. So it adds volumes to your CV if you can, have some research or academic portfolio added to surgery. Because everybody who has come out there in market has surgeries behind them. So what additionally can you give them? And also within retina, if something really clicks with you, macula clicks with you, uveitis clicks with you, pediatric retina clicks with you, try and see if you can align your academic interests and your possible publications to that. So it should all point towards one thing. If you say that, I'm interested in macular surgeries, but you have 5 publications which are in ROP, they don't go hand in hand. So you try and see that with time you align your academics, towards the core interests that you have. Prepare to be known. So as you are doing your fellowship, as you are becoming a part of the Retina fraternity, you would get good, I would say, satisfaction in peer recognition. Everybody likes that. So you chalk out important national retinal fora, make your presence felt. That making your presence felt doesn't mean that you should be invited as faculty. It means that you should be heard in relevant discussions. So it does not take anything to be present, raise up your hand and ask a relevant question. That is and that is so uncommon. You would have experiences whenever people from the dais say any questions, 99% of times there will be nothing, and it will be the people from the dais who would be so that's an opportunity, that's an open opportunity. So pick that opportunity up, try to interact, try to put across what you understand, try to ask and challenge the current knowledge that is present. Make notes, especially during surgical sessions that you're attending. A lot of people who are showing the surgeries are those who have been in this field for donkey's years, who are operating left, right, center. So these small tips you can pick up when you are looking at the beautiful treasure of videos that are being shown. So make notes which can help you go back and get better in your own surgeries. And one important thing that I feel most fellowship programs do give an exposure to, but don't give an impetus upon, you should look around and possibly sniff around and you will see these things. That is administration. Retinal surgeries are very varied, they are complex. The administrative procedure related to retinal surgeries with respect to billing, insurance, etc. is also very complex. There's a lot of work that goes on the back end. One should try to understand that, because again, operating is one element of the whole patient care. Trying to take care of your billing, finances is also something else. So interact with administrators whenever you have some amount of free time to understand how they are doing the support work that helps you do your surgeries well. And finally, a retinal fellowship decision is a commitment. There will be a lot of sacrifices coming on even personal grounds. So it has to be a calling. Unless it's a calling, it is a very tough fellowship and you should have second thoughts before entering that. Approach with good groundwork. When begun, assimilate knowledge and also disseminate it by teaching your juniors, and attempt to make your mark in the field right from the beginning. And the last point of caution, do not lose the big picture. Primarily, we are all ophthalmologists. So do not lose track of key diagnoses and emergencies of other specialties, which as a retina surgeon you should still know, so that you're able to appropriately refer and the patient doesn't get mismanaged. Right? Thank you for your kind attention. If there is time and questions, I can take, or else.
Thank you, sir. That was a beautiful presentation. One small thing I like to add here, just based on the presentation. For most of you here, choosing which place to do your fellowship from, do not go by the number of surgeries which your previous fellows have had at that institute. There are two types of learning: learning by mimicry and heuristic learning. If you go for number of surgeries and you're trying to learn by mimicry, it's not going to help. However, any center which offers you supervised training, especially in retinal surgery, one surgery of a particular kind is sufficient to help you develop in future. So don't be fooled by the number of surgeries done by X person in 3 years for deciding which institute you are going to choose.
Just a quick point as well. Dr. Dave said that it's good to focus early on in your career and try to publish ahead in even trying to laser focus within a subspecialty. I would be slightly different here. In early on in your career, just try to get in as many publications as you can. Trying to find only macular cases or trying to find only retina cases kind of limits your CV. Yeah, definitely, it shows that you are dedicated to a particular subspecialty, but early on in your career, just go ahead and try to publish whatever you can. All publications are good publications. Early on in your career, don't think about if you are the first author, last author. Any publication, as long as it is indexed, is good. Yes, definitely, when you go on and do a lot of subspecialty work, then you try to find in your niche area. But yeah, early on, try and take in whatever you get.
Yeah, I absolutely agree. What I basically meant is, as you go ahead, it automatically, the thought process comes and automatically you start getting aligned. But as you rise, any person who has risen, if you pick up the CV, you will find that the publications start aligned to a particular topic. Only then you become, somebody who has a voice or has an opinion in a particular topic.
I want to ask Dr. Dave, it was a very good talk, and especially as you mentioned about the back end of actually the functionality of retina. So I wanted to ask him whether, when do you say a retina person is actually ready to go out and practice, or whether he requires after fellowship some couple of years of going back to the institution, or whether the person should go out and then experience, because as sir was saying, one surgery per type of a case would actually be enough. So do you recommend that after 2 years or 1 year of your fellowship is more than enough for retina, or maybe you shouldn't go back, you should stay back in an institution, polish yourself more and then go out?
Actually, there is no end to what time you can stay back and keep polishing, right? So if I give you a spectrum, I think I can easily say for all retina surgeons, all of us are spinal level comfortable for retinal detachment, rhegmatogenous fresh, and everybody sweats, whatever point of your career you are, everybody sweats in a bad diabetic TRD. So there are certain things where you cannot be adequately comfortable enough, and it will always be a challenge at any stage in your career. So I think mentally, if you feel that you are okay with the basic tissue handling, a few top-ups will keep coming as and when you proceed in your career. And there will be times when you will stop and possibly you go back to focused workshops. So if you are picking up a particular skill, there are certain skill sets which you feel you are struggling with in practice. At that time, I think it's a good thing not to come to a conference like this, but look for a focused workshop on that topic, or maybe spend a few days with somebody who's really aligned to that topic, doing that thing really well. Spend some time and then maybe go back to practice.
At the end of your session, I want to add 2 slides particularly from your talk. And I feel that is relevant not only to retina, but to any other subspecialty, be it cornea, or be it anterior segment cataract, or be it pediatric. For the 2 slides were observe and listen. that is very important, because he has also mentioned quite rightly it is not the number of surgeries an institute is offering, but you need to observe carefully how your mentor is holding his instruments, how he's sitting, how he's looking at through the microscope. This is very, very important tip. And number 2 is where you mentioned that you need to do your homework before going to the OR. That applies, I feel, to everyone. Thank you so much, Dr. Dave, for pointing
you.
out
Thank
these
you.
2 slides.
So just one more thing. Now that you've seen the best of both the worlds, you've got a residency in one of the premier most institute, and also a fellowship in a place. You have talked about the attitude of a person while making the most of it. So how is the residency going to be different from when you're doing a fellowship to get the most in whatever field you choose in? So is there any difference, or you follow the same thing that you might not need a requirement for any fellowship in that particular field?
I don't think, including RP Center, I will talk. I cannot vouch for what is happening right now. I will talk from my days. I don't think residency programs anywhere in the world are tuned to teach you adequately with respect to subspecialty work. I am not saying they can't, but I think as a rule, everybody has shifted to that thought process that you possibly, this thing is what is done or dealt with in senior residency, or done or dealt with in fellowships. Because see, 3 years here and there is not going to make a difference with respect to how you are able to handle tissues. But it's just a thought process that certain things are only taught in fellowships. It would be good if sub-institute takes a lead really and tries to imbibe them in residency and see whether we can make that sort of a residency program. But what is good is, I feel, fellowship programs all over the world, I think, achieve a balancing. They average out, even if you have had a relatively weak residency program, at least in that particular subspecialty, then you are sort of on par with even people who have come from a stronger residency program.